We'll have Dr. TANDON next, and she's going to talk on the, oops, yeah, sorry, 1 minute, yeah, bioengineering the cornea.
Good evening, everybody. Thank you for inviting me to participate in this session. So I'm going to give you a little outlook about what we have done for bioengineering solutions. Not able to get it to move.
Excuse me, the slides?
Yes,
Oh,
yeah. Okay, so biomedical engineering applications with respect to cornea, let's put it at 3 levels. One is the expansion model, then there's 3D printing, and then there's gene therapy. Along with that, we also have applications of AI for diagnosis and analysis. For the purpose of this session, I'm going to focus on tissue engineering. And along with that, I'll say that when you talk about assisting recovery, we have also amniotic membrane. Let's not forget the amniotic membrane and its role in ocular surface reconstruction. So where did we start? This journey has gone on for about 20 years, where we learned that we can do a maximum manipulation of the cells outside the body and actually apply it on the human cornea and get a good result. But we ran into a very major hurdle when we came into asking for this to be accepted as a standard therapy. Since it was so complicated and it was not accepted as a standard therapy, then one resorted to SLET, which is autologous cells taken from one eye or and just put on the surface inherently. And one should not disregard the learnings we had from the previous cultured epithelial protocols, because it gave us an idea as to what worked and what didn't work and so on. So effectively, it was the lab in the eye itself. The tissue culture lab in the eye itself is where we went with the SLET. So this is the CLED journey from bench to bedside, and we've all gone through this various stages, but it also indicated to us that whatever we are talking about, cell therapy, gene therapy, everything, it's ultimately going to require regulatory approval, and we have to push for the policy change on that grounds. What we consider as accepted in peer-reviewed literature, it may not always be directly translatable at the level of policy, because they want things at the industrial level. And unfortunately, cell therapy, gene therapy, etc., to get it industry level applications, you require a big company which is going to do it. And largely, it is the research labs and clinical research kind of a scenario where this is being applied. So it is going to be the big hurdle, because it is a, we can say, orphan disease kind of a level. It is a niche area, and no big company is going to be able to take it up, because it is just simply not financially viable. So we have to have a way out. So just to look over the various interventions, have we been doing things wrong by doing these protocols? Not at all. As you can see, if you look at the various outcomes of surgical interventions for the various types of therapies, whether it was SLET, CLET, corneal keratolimbal allografts, and so on, all of them had similar anatomical success rates and good functional success rates. So if you do a systematic review, you find out that everything works. It depends upon that surgeon and the patient and that particular hospital, what is available to you and what you would able to prescribe for that particular case. So with this experience we had, and whatever we set up with the help of government support under projects, we thought we take it forward to now looking at, can we proceed with bioengineering for reconstruction of the cornea. We do know that corneal blindness is very extensive, and we do know that there is a shortage of donor corneas. We also know that with allografts, there is a risk of corneal rejection, and not all of them succeed. So therefore, lamellar keratoplasties that we are using, not suitable for surgery corneas, those corneas also, a large number of them in the country are not being used. So those corneas, if properly processed, can be used for other indications. So looking at the where can we go with the synthetic substrates, etc. We've also looked at substitutes for amniotic membrane, because there are challenges with amniotic membrane. It's not sterile, it's not, it has a shelf life, and it has a very stringent storage protocol. So can we use a scaffold or any other membrane in place? So we have looked at the use of polycaprolactone as a biosynthetic substitute for amniotic membrane. We have found that it is excellent biocompatibility. It supports supports the growth of epithelial cells. And this was important because if we put this amniotic membrane on the eye for an ocular surface burn, is it going to allow the re-epithelialization, or is it going to cause inflammation and so on? So in the lab we have shown, so this is one place where we went initially in the lab where we showed the biocompatibility. Then we proceeded to animal experiments and we were showing that there is a good re-epithelialization of a chemical injury induced by rabbit eyes and equally effective as a natural amniotic membrane. But again, we have reached that point, and then now how are we going to make it available? That is another story altogether. So tissue engineering approaches for corneal reconstruction, there again we have electrospan scaffolds, as I mentioned. We can use this PCL scaffold, again reiterating what I said before. And then we are also able to show that with this kind of a protocol of using a decellularized cornea, there was the less immunogenic cornea. So therefore, less vascularization and less immune inflammation after transplantation. So this is where we went. First, we have used cross-linked decellularized corneas in lamellar procedures in the rabbit. I would acknowledge that I used the Department of Neurosurgery Animal Lab to do the surgeries. And as you can see in this picture here, very well, beautifully integrated tissue, which has got no inflammation and well tolerated, and even the histopathology postoperatively showed that it was successful. So now are we going further with human corneas? So here I'll go give you an example of a surgery where this is the next thing that we want to do. So it is human corneas which were not suitable for optical transplantation, and almost 30 to 40,000 such corneas every year are being discarded in eye banks in India. And now can we use such corneas? So first and foremost, all such eye banks, instead of discarding such corneas, they should immediately put them into glycerol and make them available. So here's an example of a case who had an exposed haptic of sterile fixated IOL, and then instead of using fresh cornea, this is a glycerine preserved cornea, and you can see how transparent it is. So the anterior lamella is as transparent as the commercially available vision graft. So instead, we would like to encourage eye banks not to discard any cornea which is seronegative just because it has a low endothelial cell count. Put it into glycerol and somebody somewhere will find a use for it. And this is, so now the question is, in this particular case, it was a glycerol preserved cornea. The other thing is, can we use the decellularized cornea? Because the glycerol preserved cornea is very simple to preserve, but can be improve the technology by using a decellularized cornea. And that is the next, as I mentioned in the rabbit pocket surgery. So now we are looking at producing that same product for human implantation. This is what it is. So we have a non-suitable for surgery cornea. At the moment, we're using tissues which were culture positive, and then it is processed. This is how it looks so opaque when originally. And then after decellularization and cross-linking, you can see that you have a transparent tissue. And remember, we're not transplanting the full thickness cornea. It is only the anterior lamella. This is the bioreactor which is used to process the cornea for decellularization, and it's a reasonably transparent tissue. I don't think anybody will hesitate to use this tissue for anterior lamellar keratoplasties, for patch grafts, or even if they have to use a patch graft to support glaucoma drainage device. So in a nutshell, I feel that we can go ahead and we can use the corneas, at least the ones which would be unnecessarily discarded. They can be processed in this way indigenously and made available for transplantation. Thank you very much.